and say to the doctor, do you want to know why I didn't do something? Do you want to know why I didn't take my medication? And the public needs to be aware of the negativity in the medical records, and it could be related to everyone. And so please don't write the word non-compliant in my medical records without asking me why, because it could have a negative impact on my health outcomes.
I am Gloria Grace Rand, founder of The Love Method and author of the #1 Amazon bestseller, Live, Love, Engage: How to Stop Doubting Yourself and Start Being Yourself. In this podcast, we share practical advice from a spiritual perspective on how to live fully, love deeply, and engage authentically, so you can create a life and business with more impact, influence, and income. Welcome to Live, Love, Engage. Namaste. Did you know that unconscious bias, I should say, and non-compliance can have a life or death impact in a healthcare environment, especially for women and minority communities? So the author of 9 Simple Solutions to Achieve Health Equity, a guide for physicians and patients, is going to be joining us today to talk about how to advocate for yourself and loved ones in patient care. But before I bring her on, I would like to welcome those of you who are new to Live, Love, Engage and introduce myself. I am Gloria Grace. I help female entrepreneurs attract more clients with calm, clarity, and confidence by releasing negative thought patterns like self-doubt and poor self-worth. And I am really looking forward to this conversation today with Dr. Mauvareen Beverley as my guest. And I apologize if I pronounced her name wrong because I was going over it before we started, but hopefully I got it right. But I'm going to bring her on shortly. But in addition to being an author, she is a patient engagement and cultural competence specialist with 20 years of experience as an executive level physician. So I'm going to, without further ado, welcome Dr. Beverley to Live, Love, Engage. Welcome.
Thank you so much, Gloria. It's an honor to be here with you. And you did pronounce my name correctly.
Oh, good. Thank goodness. Okay. I wasn't sure. It looks easy, and yet somehow my mind is wanting to trip over it. But I want to get right into talking about, bias and health disparities that show up for women and minorities. And I'm wondering if you could share with our listeners and our audience on YouTube, what does that look like in practical terms? Maybe you can give some examples of that.
I think unconscious bias, obviously, is a stereotype about particular groups of individuals. And it does not address the reality of who that person is necessarily. And what I find the relationship, one of the common relationships in medicine is the word non-compliant. And so now there's a nicer word, non-adherent. And when the person is referred to as non-compliant, what it tells you is that the person is not following directions or not following any instructions that's given. And if you write non-compliant in the medical records 2 or 3 times, that person is under the health bus. And it's been proven that negativity in the medical records is geared more towards African Americans, particularly African American male. And when you write non-compliant, there's never a why question that's included. So we don't know why a patient didn't follow directions, but we are going to write non-compliant. And I'll give you an example how the unconscious bias and the word non-compliant was addressed in a particular patient. And so at Kings County Hospital, I was in charge of the congestive heart failure readmission prevention program. And when Medicare came in and said, if you are readmitted in 30 days, we'd only pay for 1 admission, whereas prior to that, they would pay for 2, 4, 6, 8, 10 admission. So here's an example of the non-compliant and how we saved a life when we asked the why question and eliminated the unconscious bias. 60-year-old African-American male, recently diagnosed with congestive heart failure, returns 2 weeks later, congestive heart failure decompensated due to noncompliance. My team had to ask why. And they referred to me as Dr. B. They said, please, we have to ask why, because Dr. B is going to bug out if we don't ask why. So we asked the patient, why didn't you take your medication? I can't take the water pill, which is another word for a diuretic that flushes fluid out the body so that the heart could pump better. And the problem is it makes the person urinate a lot.
Yeah.
So we asked him, why can't you take the water pill? And I'm glad you're sitting down, Gloria, because his answer was, because I drive the number 7 train.
Oh.
So the train is delayed because the driver has to find a bathroom.
Yeah.
When is your shift? 11 p.m. to 11 a.m. What do you do when you get home? I do some chores. I make breakfast. I take some of my medications, but if I'm going on my shift, I don't take the water pill. We brought this to the attention of the cardiologist, the same cardiologist who was ignoring him. And he said, okay, take the water pill when you get home. Be aware it may wake you up during the day, but by the time you get to your shift, you'll have less of a reason to urinate. And to the degree that you do, we're going to give you a cubicle to use in the private space. And you know what the patient's response was? If I knew I had to choose between peeing and breathing, I would have been breathing.
Yeah, I think so.
The conversation. So without the why question, he would have been readmitted multiple times. And who's going to care about him?
Yeah.
And if he were to pass at mortality, it would have said died due to noncompliance. But the key takeaway from this particular case, the patient, we made it such that the patient didn't have to choose between his job and his health. But also that we recognize him as a human being, and we needed to know why he couldn't follow direction. Yeah. And in my experience, asking the why question resulted in a lot of better health outcomes. Did it solve all the problems? No, but it solved a large percentage of what could be mortality.
Yeah, absolutely. I can understand that, because I can also understand it from the point of view of the patient, and and his not wanting to do that. And I guess there's one of the issues is that we really do need to not be afraid of speaking up to healthcare providers and to ask questions. And I suppose, he might, he may have thought that, but maybe he didn't feel comfortable even enough to ask it. So I'm so glad that you were an advocate, but I guess that's why you kind of wrote the book. I mean, tell me a little bit about that. Is that kind of one of the reasons about that?
And it's what I refer to in my book as stop in my tracks moments that led to boots on the ground, simple solution. And the stop in my tracks moment came from speaking to patients and recognizing that currently in healthcare, and also the topic of health disparity, and everything now is nicer words. Now there's health equity. The patients are not included in the solution. And in my book, the stop in my tracks moments came from patients that actually led to boots on the ground, simple solution. And it was humbling. And what I realized is that obviously heart failure is age-related. Most of the cohort of patients were between 60 and 92. And what I realized is that the English-speaking African-American population is not included in the cultural competence conversation. The elderly Black population has the worst health outcomes in all disease categories. When you consider the atrocities that they endured, it's unacceptable. Yeah. And again, one of my stop in my tracks moments, went in to see a patient in Brooklyn, is what I call the merging of the African diaspora. It was a large Caribbean population. There's a large African American, and the Spanish population were interested. They weren't from Dominican Republic or Puerto Rico or Mexico. They were Panamanians. And under colonial rule, the British sent the English-speaking population to Panama to do what? To build a canal. So they have English and Spanish name, Ronaldo, Austin, Antonio, Martin. And typically they look Black, and the top language was English. And the bulk of the patients from that were African American came from the Carolinas. And I'm saying to myself, why is everybody from the Carolinas? Virginia is sort of down the street from us. And what I had to do the research after the Emancipation Proclamation, when blacks had their first representation in Congress, their communities did better than their white counterpart. They built church, they built schools, they built businesses. The plantation owner property went south because nobody was picking the cotton. And over the course of time, the Ku Klux Klan came in and burned the place down. And they came up the coastline to New York. And so in terms of cultural competence, I told the team, you really have to ask, where's the patient from? Because what I call the lookalike syndrome, and I'll give you an example what I mean by that. We went in to see a patient when I was at Queen's Hospital, and he was Indian. And the team said, oh, where in India you're from? He said, I'm not from India, I'm Guyanese, I'm Caribbean. So it's what I call the lookalike syndrome. Go tell a British person they're Irish and see how far you get. Go tell a Chinese they're Japanese. Go tell a Jamaican they're Trinidadian. Tell a Nigerian that they're Ghanaian. And most important, go tell a New Yorker they're from New Jersey and see how far.
As my mother said, you can't assume. You just can't assume.
If you miss some of the unique cultural differences, it could impact the health outcome. Yeah. Because again, it's perception about people versus the reality. So I went in to see a patient, and she was 80 years old. And as part of the stop in my tracks moment, and I said, where are you from? She said, South Carolina. And what I was thinking put on my clinical hat, I was going to ask the next, are you visiting New York or do you live here? Because if you're visiting and you got sick, it's a different situation than if you live here. And right. Gloria, Monday morning, 9 o'clock, you know what she said? The next statement, before I even asked that question, my parents were a step away from slavery and my grandparents were slaves.
Oh, wow.
Was I expecting that Monday morning, 9 o'clock?
No.
And I said, tell me about it. And some of them spoke in codes. My family picked cotton on a plantation that was not ours. And we had to get up at the crack of dawn and pick 300 to 500 pounds of cotton. And then I had to walk 10 miles to a segregated school. And I'm saying 10 miles, we can't even go 5 blocks without calling an Uber, So
yeah.
I had to walk 10 miles. And the body language and her tone changed. She said, if you want an education, you had to. Like, a part of this, don't you get stupid? And I said, did you have to walk back? She said, no, the principal in the horse-drawn carriage. And they had to get back before dark, before the Ku Klux Klan. I said, how old were you? She said, 10 years old. Could you imagine?
Wow.
So she continued her education. She went to Voorhees College. It's a 2-year black college in South Carolina. She came to New York. The migration was in the 30s and the 40s. And she continued her education, became a dietitian. I don't know if you're familiar with Stuyvesant High School. It's a top of the tier school in New York. It outshadows the private and public school. And her 2 children were 2 of 5 black children to integrate Stuyvesant High School. And it was humbling. And I said to her, you're going to need home care services. And her response was, I don't want anything that's not mine. She thought I was giving her a handout. And I told my team, whether if the patient is upset about what you may have said, whether you meant it or not, apologize. I said, I'm so sorry. Maybe I could have explained it a little bit different. I said, everyone that has Medicare I didn't use the word entitled. Everyone that has Medicare has home care. She says, everyone? I said, yes. I said, do you mind telling me when you retired? She said, in 2000. I said, do you mind me telling you how much you made? She said, $200 a week, but others made more. Read between the lines.
Yeah.
It was learning from the cultural, and that's when I realized they are not included. And cultural competence has to be a part of the conversation. It has to be American-born physicians to foreign-born patients, but also foreign-born physicians to American-born patients.
Yeah.
American-born physicians to American-born patients who are different than themselves. And the role of religion in these populations was pivotal to their survival. And I've done presentation and I made the point. I said, when a Holocaust survivor comes in the hospital, we roll out the red carpet. The chief medical officer, the board of directors, the CEO, the rabbi will go and see that patient. And so they should, because of the horrific circumstances that they endured. But when an
Mm.
elderly black person who fled the South because of Ku Klux Klan, lynching, and Jim Crow, how come we don't roll out the red carpet? And
Yeah.
maybe it's an opportunity to recognize all atrocity survivors the same, and to
Hmm.
recognize the role of religion in these two populations were pivotal to their survival.
Yeah.
And we were able, it's a lot of things that we put in place, but we were able to decrease readmission from 30% to 18.7 in just about 2 years. The
Oh, wonderful.
population didn't change, the clinical care, the so-called social determinants of health didn't change. It's not like a whole
Yeah.
bunch of people came in on the 18.7. What changed was the heightened human value.
Mm.
Never use the word non-compliant without asking why.
Yeah.
Collaborate with patients and eliminate the perception versus the reality of who that individual in that bed is.
All
And
right.
I think with the team was amazing. Teamwork from all races. We had we had black team, we had whites, we had acidic, amazing Jewish pharmacists, and we all got together and we all collaborated in a very positive and and people said that, oh wow, that was a lot. Well, you guys must have been stressed out. And the team said, no, we weren't stressed out. We were having fun.
Well, that's good. Well, let's get into how we can be our advocates. So your book has 9 simple solutions. We're not going to go over all 9 of them in the podcast because you need to get the book. But if you could pick 2 of those solutions that people could use, which ones would you choose and why? That
Okay.
are the most important?
I think the two that I would select again, as a focus, and I may be repetitive, but if you didn't follow directions and the doctor asks whether you're in the hospital or in the private practice, did you take your medications? And you say no, or did you follow directions, whatever those directions are, and you say no, wait a couple of seconds and say to the doctor, do you want to know why I didn't do something? Do you want to know why I didn't take my medication? And the public needs to be aware of the negativity in the medical records, and it could be related to everyone. And so please don't write the word non-compliant in my medical records without asking me why, because it could have a negative impact on my health outcomes. The other thing that I would recommend currently in the social history, it just says non-drinker, non-smoker, no toxic substance. When I trained in medical school and when I completed my internship and residency, the social history had to be more comprehensive because it gives you a sense of who that individual is. We had to say the age of the person, the gender, the race, whether the person was employed or unemployed, the family, in who does the patient live with, and then ask whether the person was a smoker or a drinker or addicted to narcotics. But it wasn't just limited to non-drinker, non-smoker, no toxic substance. So how does that would help? Could you imagine an 80-year-old African American woman or any elderly patient who has been in church since birth, regardless of what the religion is, and that's how that person is being described in the book, in the medical records. Non-drinker, non-smoker, no toxic substance. What does that tell you about the system? Is that information going to let the physician, the nurse, or the care case manager more receptive to understanding who you are?
Hmm.
You know,
Not necessarily, yeah.
and I think for everyone, and it's irrespective of age, gender, race, make sure ask about. So what's included in my social history?
Hmm. Yeah,
You
that's
know,
good. Yeah, that's true. And that seems like an easy question to ask.
yeah,
It's not,
yeah,
it's not, you're not being argumentative or anything. You're just
no,
inquiring, you're
yes,
just saying, just, hey, I'm
yes,
curious. What's in there?
yes, yes, because if that's what they come up with, and then the response could be, well, that's not who I am.
Hmm.
Let me tell you who I am.
Yeah.
I am married. I'm not married. I'm employed. I'm not employed. Level of education. I live at home with family members or I live alone. And I do smoke, but I don't drink and I don't take toxic substance, or I do smoke and I drink. And then, they could have a different conversation.
Yeah. And I would think, and maybe you can address this better as a physician yourself,
Yeah.
would are physicians happy to hear that, to be able to get, feedback from like their patient to be able to, advocate for themselves? I mean, are they open to that? Are you finding that, or maybe not? I mean, and maybe it still needs to
Yeah.
educate our physicians as well.
Yeah. I think, and that's why I do patient engagement and cultural competence training.
Hmm.
And it's about expanding the conversation.
Hmm.
And as I said, we're trained to do no harm. And I think once you put that in the minds of the clinical team and say, this is what the circumstances, and you have to make these changes, and to recognize and to be honest that, and I show the literature, what I'm saying is not something I think about, or I think that it's in the medical literature.
Hmm.
That the negativity in the medical records are geared more towards African Americans, particularly African American males. So we have to fix that. But the conversation could expand to everyone,
Mm-hmm. Yeah.
everyone. And so everyone needs to know what's in my medical record. Because when you have this medical record there, you could go online, but it doesn't show you what your social history is and the
Right.
negativity. And it's important to understand that. I really do think it can make a change.
Mm.
Because if patients, I don't care who that person is, what age, what disease, what entity, and ask me, do you want to know why I did do something? So what is the doctor going to say? No, I don't want to know why.
Yeah.
And
Hopefully
so
not.
yeah,
And if
it's an opportunity to get to know who you are, and also for the patient to get to know who the doctor is at this point.
yeah.
And everybody said the doctors are stressed out. It's too many people. But what we realized that once we saw good results, no, the stress level was low. Could you imagine if patients were being readmitted multiple times? That was what's causing the stress. But if you
That's
decrease
cool.
the readmission, then the stress level for that particular circumstance is
Mm.
less. And the
That's
team
true.
would come in and said, "Oh, Dr. B, can you help us with John Brown?" So you get a different culture. What you want to
Yeah.
change the culture in the institution, and I think it's doable because I experienced it.
Absolutely. And it's just occurring to me as you're saying that, because I can put myself in the shoes of a doctor saying, "Oh no, this guy's coming in again. What's his problem now?" But if they'd taken the time at the beginning to really have this discussion, to really see who they are as you're
Yeah.
talking about, then he wouldn't have to see them as see that person as often, because they'd be taking better care of themselves and following directions.
And I'll give you one example, which was education for me because it came about the relationship between patient fears and noncompliance.
Hmm.
So there was a patient whose kidney functions were failing,
Hmm.
and he refused dialysis. And every time he went to the ambulatory care appointment for the for with the nephrologist, all the doctor wrote was patient refused, patient refused. So the patient was admitted, and I said to the team, "Does anybody speak to his wife? Does his wife come to visit him?" She said, "Yes, he comes. She comes every evening after 5 o'clock after work." So I said, "Let me wait and let's speak to her because if anybody's going to convince him, his wife is going to convince him." That was my thought process. I waited. I saw her after 5, and I told her, "I know you love your husband, but his kidney functions are worsening, and if you don't convince him to have dialysis, he may not be here with you, much longer." And she said a statement just blew my mind. She says, "I don't think I want to do that." And I'm saying, "What?" And again, the why question, tell me why. And she said another powerful statement. "I don't think I could live with myself." That statement resonated with me. And I said, "Tell me why." And she said, "Our neighbor down the hall went on dialysis, and 2 weeks later, he died." Could you imagine the trauma,
Oh.
the mental, emotional trauma, if that happened to her husband and she was consider herself responsible? How much of
Mhm.
us would have put our family members on dialysis? I
Yeah.
brought in, again, the change in mindset. I brought in a nephrologist. I told him the story. And I said, they're going to need hand holding. So he went to see them and he said, "I don't know why your neighbor passed. He could have had a stroke, could have had a heart attack, his kidneys could have failed. But here is the change that I think is so positive. He said, if you agree to dialysis, I will be there with you for the first week. Nephrologists don't go to dialysis for patients. They refer patients to dialysis service.
Yeah.
And he did. And the patient did better, you know? And I thought from a relationship between, when people talk about non-compliance now in my mind, I wonder what does the fear factor play into this?
Yeah.
And so I developed what I call the SPOT methodology. S, speak to patients and family. O, outline what's important to the individual. I'm sorry, S, sorry. Speak to patients and family. P, pacify fears. O, outline what's important to the individual. And T, take into account the time it takes for somebody to accept the disease. Because if I'm going on vacation with my family, I got my mammogram and it's positive, I may not know who I am at that point.
Right. Yeah.
So that's also part of the solution. One of the solutions, adopt the SPOT methodology. And you know, it was a really humbling and informative and educational experience.
Oh, yeah.
And that's why I wrote the book. Simple Solutions to Achieve Health Equity, a guide for healthcare professionals and patients. And it's available right now on Amazon.
Very good.
It's the #1 bestseller for new releases. And
Congrats.
the book came out on Juneteenth, which is a federal holiday, the end of February, and it's my birthday.
Oh, well, very good. Doubly good day then. I love that. Yes. I like that one. That works.
And yes, and it's really, I think, informative.
Yeah.
And like I said, if we solve the simple, it doesn't have to get to the complex. And the last thing I'm going to say on it, one of the common thread, the human experience. So when I do presentations, which I did at various hospitals, and I would say, what is the similarity between a homeless person and a millionaire? And the intern in front and the front row seat said, the look on his face, said, are you kidding me? The only thing I could think about is that they are men. I said, well, they could be females too, but that's another story. I said, what is the common thread? Once accurately diagnosed, there is nobody on planet Earth could give it back, regardless of race, gender, ethnicity, social, economic status, language, whatever the circumstances. The billionaire can't say, oh, I'll give you $1 million to take the cancer back. Oh, that's not enough. I'll give you $5 million. It's non-negotiable. That's the only thing in life, and from my experience, that's the common thread. You know, if you don't like, we have choices in life. You don't like the school your kids go to, you could change. You don't like your job, you could leave. You don't like your family, you can move to another state. You know, but once accurately diagnosed, it's non-negotiable across the board. And so maybe hospitals could adopt the principle of the common thread and be more empathetic and less judgmental. As I repeated in the past, as I said before, and to recognize the bulk of us taking care of patients never laid in a hospital beds, and those that are dual women delivering life, and in cases patients are trying to prevent death. Now, how you deal with your condition could be your own personal belief system, your culture, and what's available to you.
Yeah.
But the underlying factor is the common thread.
Yeah, definitely. Oh, this has been very educational for me, and I know that it's providing a lot of value, and this is definitely something that I encourage everyone to check this out. and because, you know, even if it's not necessarily for you, but it could be for a loved one, you know, so you can help them out, you know, as we're, you know, in this day and age, we've got baby boomers are getting older all the time, but we're also living longer. And, you know, although sometimes they say no, but whatever, it's still, you need to take care of yourself no matter what age you are, and you need to be your own best advocate. So I appreciate that. How can people learn more about what you do? Maybe they want to even have you speak at an organization or something, or where they can get the book, and what's the best place for people to reach you?
So my email address is mbeverley@gmail.com. And I'll give my website is drbeverley.com. And my phone number is 914-409-2766. I'm still old school with the phone number. Call me. Can I speak to a human being? That would be, you know.
Oh, wonderful.
But, and the book is available on Amazon, and you can actually go to the website, and there's a page there that you could just order the book. And I just show you a picture of the book to everyone.
All right, there we go. 9 simple solutions to achieve health equity. All right, very good. And the website for those listening, it's Dr. Beverley, and Beverley is spelled Beverley. So we got 3 E's in there.
And there's no dot between Beverley. It's Dr. Beverley.
Exactly. All right. Well, I will have all that. I will have all that in the show notes anyway. So you can go to liveloveengagepodcast.com and you'll be able to get that. So thank you so much for being with us today. I really appreciate it. And I wish you good luck with the work that you're doing in the world for, educating and healing. And and hope the book continues to do well.
Thank you so much. And I'll just leave everybody with the note, even in life, it's not just in healthcare. In our personal lives, our professional lives, our family life, if we solve the simple, it doesn't necessarily have to escalate to the complex. So think about in your own life, things that are simple, that are solvable. Don't wait till it escalates.
That's true. Yeah, good advice. I like that. Yeah, exactly. Fix it while it's easy to fix before things get out of hand, for sure. I love that. Thank you.
And thank you, Gloria. This has been really great.
And I do want to thank all of you for joining us today, for listening and for watching on YouTube. And I really appreciate it. I have some special news that I want to share, if I can figure out where to put it up here. There we go. So I have been nominated. Well, our Live, Love, Engage has been nominated for a, let's see if I can show it. No, I can't show the background right now. Oh, that's okay. Anyway, we've been nominated for a Women in Podcasting Award in the Mindset category. So if voting goes from August 1st through October 1st of 2024, and you can vote for us at womeninpodcasting.net/awards, and then you'll be able to find it. And I will have that link in the show notes as well. So I hope you will, if you've been enjoying the show, I hope you will reach out and give us a vote. There's no cost for it. So, so it's easy peasy. And I think that's about it. And of course, if you're not subscribed to the show, I hope you will subscribe to us on your favorite podcast platform or on YouTube. And I think that's going to do it. So until next time, this is Gloria Grace, and I encourage you to go out and live fully, love deeply, and engage authentically.